Hello again, this is Miss James. I was going to make a video of myself while I'm teaching you this. I still might on some of the important points, but so that you can go over it. These is just a continuation of what we were talking about last week of the complications that moms can get into and the adaptations. And this is more of the application from I believe it was chapter 20 that we were talking about last week. Those of you who's been in clinical, y'all know it takes a lot of teamwork to do our job, and if you've got a good team, you can get it all done. During the postpartum period, the adaptations that mom are going to go through starts with the physiological adaptations, which is the uterine involution process. This is the best indicator that mom's uterus and her body is physiologically working to get back to normal. The fundus tells us if it's contracting, lets us know if she may have a bladder that is not emptying. It also lets us know if she could be hemorrhaging. And there's the same picture in your book. I took this from a different resource that I like to use, but gives you an idea of where the tip of the fundus is from day 1 all the way down to day 9, whenever it should be getting back down into the pelvis. Usually 1 centimeter a day unless there's a problem. Sometimes multips tend to take just a little bit longer, but for most part between 1 to 10 days she should be back to normal. This is a picture of a bladder that is full, displacing the uterus to the right like we talked about last week, and the uterus would feel boggy and she would need to empty her bladder to hopefully get a better assessment. Okay, who will have a slower involution process? I already mentioned one, a multip, one that's had more than one. Women who have an overdistended uterus, one who has experienced an infection, or one who has retained placental tissue. We were wondering about some scans that are done for all the women after delivery, looking for retained laparotomy pads or anything that was used during the delivery. It should also be used to see if there could be any type of retained tissue that's inside a retained placenta. Who could have a potentially faster involution process? Any ideas? So to look that up and find out. Alright, after pains. Who has more after pains? Some of you may have experienced some of these women in clinical this week. More after pains can be experienced by a multipara, one who has an overdistension of the uterus, or a breastfeeding mother. So our focus of care is going to be on helping them to manage their pain, and this could either be through medications or positioning and through reassurance that it will get better. I think often we jump to the pain medication first before we try to help them with other things that can assist them, like warm compresses, changing their position, getting up and walking whenever it's safe to do so. We've talked about lochia several times. It's rubra day 1 to 3, and then a little lighter with serosa 4 to 10, and alba, which is almost a white, kind of pinkish tinged, really, 11 to 21. And just know these different colors because some women will go back and forth. Sometimes the lochia will stop and it'll start back. If she's breastfeeding, sometimes she continues to have some lochia, kind of like menstrual flow. So I'm not going to ask you to memorize hard and fast. Just realize at first it's rubra, then serosa, then alba, and no a time frame. The amounts are termed as scant, light, moderate, and heavy, and we would look for you to use these terms whenever you're charting what the lochia looks like. Who's a fall risk? Why is she considered a fall risk during the intrapartum period and the postpartum period? Why intrapartum? Well, her gait is waddly, and then when she comes in labor, we're giving her medications that could make her a fall risk, especially after she's had an epidural or if she's receiving Stadol. Postpartum, why would she be a fall risk? Is her equilibrium still a little off? She's gone from a pretty intense cardiac volume to one that's trying to normalize. She may be on pain medication. What are some other reasons? Why do we want to make sure that the bed is left low, 2 side rails up, things within reach, and we want to make sure we're checking on her? Neurologically, after birth, some of these pages may be a little off because I have taken a combination of information that I like to give y'all. So if you look up these charts in chapter 22, you will find them. Neurologically, naturally, she's sleep deprived. She may have a headache from either hypertension or from the epidural, which sometimes it does happen, and they have to insert a blood patch to help release the headache because she's having some leaking spinal fluid. We need to screen them for an exacerbation of preeclampsia, which is hypertensive, proteinuria. She may have blurry vision. She may be sensitive to light, or she may start complaining of abdominal pain. And there's differences in mild, severe preeclampsia and eclampsia. So look those up in your book. And what is the main difference? And it's seizures. Preeclamptic, high blood pressure, seeing spots, visual changes, to the point that if her pressure gets too high, she could begin having seizures, and we really do not want that to happen while she is still pregnant. And we definitely don't want her to start having seizures while she's caring for the baby, because she could fall, she could drop the baby. Contraception during breastfeeding, menses will usually return between 12 weeks to sometimes 18-month-old babies. Sometimes it'll take it that long. So she really needs to talk to her physician about appropriate contraception, because breastfeeding is not a contraceptive. The frequency and the duration of the breastfeeding has a huge impact on how long it takes before menses begins again. So by the time the baby is 6 months, she needs to make sure she's very consistent with contraception. But this could be a misnomer. She really needs to get on contraception as soon as it's safe to do so. Bottle feeding, if she's bottle feeding, her menses should begin within 9 weeks or so, and these time frames are relative, because if she had issues with menstrual cycles before, sometimes she may be a little irregular getting started back. Usually the breast should not become sore and firm. Her milk usually does not come in for the first 48 hours. Sometimes they'll start saying they're sore, but if the baby is breastfeeding, sometimes the baby is not breastfeeding correctly, just sucking on the nipple like a pacifier, and that part will become sore, but her breasts usually do not fill up within until about 2 days after birth. We need to observe for flat and inverted nipples because there are nipple shields that we can use to help with that. Observe for any dimples in the breasts, and remind mom a good supportive bra needs to be worn. What she can do if she's hurting, changing the sides from one breast to the other. I know Miss Bradford has talked to you a lot about breastfeeding, so this is rather redundant from what we've already talked about. And hygiene is important. What are sitz baths used for? Take a look in your book. Why do we use them? How often are they safe? And what does the water temperature needs to be? Not hot. Warm sitz baths are good if she's had an episiotomy or if she has some terrible hemorrhoids. And after the first 24 hours would be whenever sitz baths could be used, whenever it's safe to immerse the stitches. But we want to make sure the sitz bath is very clean so that she won't use any infection. Cesarean teaching, no heavy lifting. The incision cannot be submerged in a tub. Keep the incision clean and dry. No driving while taking narcotics, and she needs to be given the instructions on when to call the physician. Temperature over 100.4. Any kind of diaphoresis or sweating or feeling funny. Any kind of looks of infection around the incision site. I know we have all the Dermabond and Intercede and those types of things, but we still need to encourage her about maintaining good hygiene and keeping hands away from the incision site, keeping that area clean and dry. For bottle feeding moms, they still need to wear a good snug bra 24/7. She can use ice packs for the pain. If she takes warm water showers, her breasts are going to hurt and be engorged until her milk dries up. If she pumps or massages, it's just going to continue. If she leaves everything alone because it's based on supply and demand, she should return to normal within 72 hours. Cold cabbage leaves are good to help with the pain. But if she any kind of stimulation will make the milk continue to come in. We don't give medications, and we don't wrap her up in ACE wrap anymore. Sexual activity after bleeding has subsided and perineal pain has resolved. The average is in 2 to 4 weeks, or up to 6 months for lacerations and trauma. It's very important for us to talk to mom and explain she needs a pelvic rest. Now, does everyone always follow these instructions? No, they do not. But this is what's safer for her, help her to heal back as she should, and her pelvis and everything internally needs a rest after labor and delivery. Psychosocially, bonding with the infant is very, very important. Not every mom bonds the same as others, so it's important for us to observe what's normal for this mother. It's a process between the parent and the infant. It occurs at or soon after birth, but it's only one brief phase in the development of this relationship, and it's important for both the mom and the dad or the significant other during this period. So babies who have to be pulled away and taken to NICU, sometimes this period of time is interrupted. Attachment is a two-way bond of affection between two people, and this is what ties families together: the parents, the siblings, and all of their children, including the new baby. And it's very important that we enhance this relationship. Maternal touch. This is what is very important whenever mom is looking at the baby. It's the in-face position and mutual gaze, and then touching the fingertips and toes, the palm sides of the hands, and she just enfolds the infant in her arms and binding in, holding that baby close in. These are very important aspects of maternal touch. Riva Rubin, we've talked about the Rubin stages before, and your chapter talks about it a little bit more with the taking in and the taking hold phase. Taking in is whenever, right after birth, I'm mainly focused on myself and getting myself back into shape, because I've just gotten through labor or cesarean, and so I'm focused on my needs for food and sleep, and I'd rather you just make those decisions for me right now, and sometimes this can take up to 2 days. Then finally I'm ready to take hold and become more independent, taking care of myself and caring for my newborn. If it's my first baby, a lot of times I'm worried about my competence as a mother, and this usually can go on for several days. Then the taking hold, this is the time that it's more of a teachable moment, and we can impose new ideas for mom if we see that she needs some extra teaching and if she needs some services available. Because there are some moms who do need some extra help. And considering our economy these days, there's lots of help out there, and we need to help them understand where they can go. The letting go phase is she's no longer able to do all the things that she was doing prior to, just a carefree lifestyle. She may not have had an ideal birth experience, but that's okay. This was her experience, and she may have an infant that doesn't look just like what she was expecting, but she's letting go of that too, because she has a beautiful baby now, and all of those things need to go away. During taking in, we realize this, and we don't want to overly expect her to do anything. We want to make sure that she's having rest, she's getting her nutrition, she's starting to take in some fluids, and we want her to start feeling better. We need to let her to express her feelings and decide if she needs any kind of support. We want her to start taking on her maternal role after her first day or two. We want her to start seeing how she's going to do in this maternal role, and give her opportunities to take care of the baby while we're still there and able to help her. We want to give reinforcement, and if we see her doing something that needs to be different, we carefully and compassionately help her in those caretaking behaviors. We want to teach her. During the letting go phase, we let her express her feelings about not being able to do the things that she was doing initially, going out with friends all of the time and having a good time because now she has a baby, and give her appropriate sources for assistance based on her needs. Paternal adjustment, this is the father. Engrossment, this is his absorption into the new baby. If it's not the father, whoever the significant other or the support person is going to be, they become preoccupied with the baby, and they're more interested in the infant, and it's important that we support this role. So now we're going to move on into postpartum depression and mood disorders. Some of this information I use from a nurse who put this presentation together, but the information is the same in your book. The perinatal mood disorders are considered depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, psychosis, and bipolar. Sometimes, if individuals already have these mood disorders, pregnancy often will exacerbate them, or during the postpartum period, these disorders may get worse. And so it's important for us to be aware of them so that we can recognize them and get these women help that they need, so they will not harm themselves, their babies or others. The incidence of prenatal mood disorders during pregnancy is 7 to 22%. The baby blues, this is just the normal postpartum depression that occurs right after a baby while we're going through all these hormonal changes. That affects 80%. Postpartum depression is 10 to 20%, and then 1 or 2 in every 1,000 births experience postpartum psychosis. And these are the ones who you hear about on the news or read about. They get to the point that they're either drowning their children or doing other things to kill their babies because they're in this psychotic state, and no one has recognized it or helped them to get what they need so that this doesn't happen. Postpartum blues, this is the transient period of depression after she's gotten away from all of the help that she had in school, in the hospital, and she's having to take care of things, and she's taking care of herself too. So often they'll be crying, they'll be irritable, a little anxious. They're on a roller coaster from anger to irritable to happy to sad. They may have insomnia, restlessness, very exhausted, very tense, can't concentrate very well, and this doesn't last, should not last more than up until the 6-week checkup. Because of rapid hormonal changes, the stress of labor, she's not comfortable. She was pregnant and happy, feeling the baby move, and this is a general letdown after the pregnancy and the birth. Now she's feeling more responsible. She's not getting enough sleep, and if something was wrong with the baby, or the baby was sick, or something else didn't work out just right, she's feeling disappointed because this is the real world now and it wasn't quite what she. We want to help recognize that, and so I have some information if you're interested. There is a hospital in Florida that has a screening that they do for every mom, so they can recognize if mother has a potential for going into postpartum depression or postpartum psychosis after she gets home, so that they can find her the help that she needs. They have sessions where moms can come in as support groups and talk, and they can recognize that mom may be getting to the point where she's going to hurt herself or hurt others. And there have been some women that these nurses have identified that have ended up having to be institutionalized to protect themselves and protect their babies. Hemorrhage, what is it? It's very life-threatening. It's the leading cause of maternal death, and it can happen as soon as 4 hours after birth. The blood loss is greater than 500 milliliters after vaginal, or greater than 1,000 milliliters after a cesarean. The most common cause is a uterus that is not clamping down, which is called uterine atony. It's like a muscle that has worked too hard and it just does not get tight anymore. The other causes could be from lacerations, from episiotomies of retained placenta, a uterine inversion, coagulation problems, a large for gestational age baby, failure to progress a labor. The longer it goes, sometimes the more apt the mom may be to hemorrhage, and there's many other causes that she can hemorrhage. The 5 T's, and in your book it mixes you up, so if you go by the 5 T's here, then you'll be fine, because the T's in your book are written 2 different ways. Tone, atony or a distended bladder, tissue, retained placenta and clots, trauma from vaginal, cervical, or injury to the uterus, thrombin, which would be coagulation issues, either pre-existing or acquired, because we all know, and we say it over and over again, pregnancy is a hypercoagulable state, or traction on the umbilical cord, which causes a uterine inversion. Traction should never, ever, ever occur. And there's a table in your book. If it's not 22.2, it's somewhere. It is 22.2, but I'm not certain of the page number, but please look it up. Nursing assessment, we need to assess for the risk factors, assess for the amount of bleeding. Most deaths will result from an untreated, slow, steady blood loss. It may be just a slow trickle of blood that we're seeing from the vaginal area, and that could be a sign that she is hemorrhaging. We need to assess for hematoma. There's a picture in your book of a really large bump on the side of an episiotomy that is a hematoma. What are our first steps for excessive bleeding? We know we want to feel the fundus. Is it boggy? Is it mushy? Is she passing clots? And this is after you've determined if the bladder is full. We need a good baseline vital signs, and if she is excessively bleeding, we've got to do all we can to support her. Call the doctor. Fundal massage, IV fluids, Pitocin. If these fail, then he or she is going to get into more aggressive measures, which is a bimanual compression, one hand on top of the uterus, one hand inside the vagina to do a bimanual compression of the uterus. Internal packing or a balloon tamponade, which this would be a Bakri, B-A-K-R-I. It's a catheter that looks like a Foley catheter that would be inserted into the uterus with a balloon blown up to try to add pressure to keep her from bleeding. Now, if she is really unstable, she is going to be going to surgery. The primary infusion is going to be running. You need to plan on starting a second infusion, because if she's getting Pitocin in one line and she's going to be getting a transfusion in another line, number one, the two do not need to mix. But the other thing is, we want her to be able to receive her Pitocin and her fluids at the same time while she's receiving her blood. She's going to get vital signs every 15 to 30 minutes. We have to check her level of consciousness and plan for a possible dilatation and curettage. To go to OR, let the physician go in, clean out her uterus really well, and see if there are any lacerations that were missed or anything going on that needs to be taken care of. If it's really bad, sometimes she may end up with an emergency hysterectomy. She needs to be assessed for hypovolemic shock because she's losing a lot of blood, and she is very at risk for that. We're not going to talk a lot about DIC, but being aware that if her clotting factors do start becoming all out of range and she may be bleeding here and clotting there, she can go into disseminated intravascular coagulation, and that's a very emergent situation, and you're running close to losing your mother. Predisposing factors: an overdistended uterus, multiple gestations, a large infant, hydramnios. If she's multiparity, if she's been pregnant more than 5 times, our use of tocolytic drugs, oxytocin. If she's had a precipitate labor or delivery, that means a fast labor, one that starts really fast, or a delivery that is really fast. Or if she's had a prolonged labor, if we've used forceps or a vacuum extractor, if she's had a cesarean birth, if we've had to manually remove the placenta, if she's got a history of a postpartum hemorrhage, if she's been under general anesthesia. See, you can see multiple chances for a postpartum hemorrhage and we need to really monitor our moms during the postpartum period. Additional factors: her placenta could have been implanted very low. We may have had to give her magnesium sulfate for a reason. She may have predisposing clotting disorders, or she could have had a previous uterine surgery, a previous cesarean section, a previous classical incision. The labs that we obtain if we suspect hemorrhage: fibrinogen, a prothrombin time, a partial prothrombin time, because I always call it a PTT, platelets, and a D dimer. And you can look these up in your book, so that we will know if she's running the risk of a severe hemorrhage, or if she's having any, if she has any factors at all. Management for atony: massage the fundus and express the clots. We pharmacologically will give her a rapid IV infusion with Pitocin. Methergin, Hemabate, Cytotec. What you need to remember about Hemabate: if she has a history of asthma, we cannot give her Hemabate. It is highly contraindicated. We want to make sure she's got good IVs running, because she's probably going to need blood replacement, and this is when she's going to need 2 lines. She will possibly need a bimanual compression of the uterus and possibly an emergency hysterectomy. Massaging, continuing to massage a fundus that is not clamping down, is not the answer. We cannot continue to massage a boggy fundus. When massage, it doesn't firm up, then something else has to be done, because if you keep going over and over and over again, it is not going to firm up without further treatment. This is a picture of a bimanual compression. Continuing the uterine atony treatment would be vaginal packing, exploration of the uterine cavity to search for placental fragments. The physician may have to insert uterine compression sutures. She's going to need large bore IV sites, at least a 20 to a 18 gauge, and you need to go ahead and make sure she's been typed and cross-matched for blood and clotting studies are done, because everything is moving really quickly. What should we suspect when the fundus is firm, midline at the umbilicus, but the bleeding is bright red? She has birth canal trauma. Lacerations can be at the cervical site, vaginal, or perineal. She could also develop hematomas, and it could also be from vacuum or forceps, and that's a picture of what one would look like. The therapeutic management would depend on where the hematoma is and what the physician, if she's hemorrhaging or not. Late postpartum hemorrhage is caused from a subinvolution of the uterus, retained placental fragments, or an infection. So it's very important that we teach mom about things that she needs to call for, because we're usually sending her home in a couple of days, and a hemorrhage still could happen. That's why she doesn't go home and start washing clothes and mopping the floors. She needs to go home and follow her discharge instructions. If she does develop a late postpartum hemorrhage, she'll have to come in. The physician will have to do a manual exploration with a sonogram or do a dilation curettage. She will go on broad spectrum antibiotics and may end up needing to take methergin or oxytocin. Tachycardia is a what type of symptom for hypovolemic shock? It is late. Thromboembolic disorders, DVTs, superficial vein thrombosis usually happens in the lower legs, and it's usually along the saphenous vein. Some women are predisposed to having these types of veins in their legs when they get pregnant, and so we have to be cognizant of that. DVTs come from foot to iliofemoral region. With both types, she runs a risk of developing a pulmonary embolus that would break off from this area and travel to the pulmonary. Collection of platelets or fibrin on a vessel wall. What would this cause? A thrombus. The major causes of thrombosis are venous stasis and endothelial layer injury to the blood vessel. So what do we tell our moms to do about venous stasis? To prop her feet up every now and then, not stand up for long periods of time, not sitting for long periods of time either, or if there's an injury to the blood vessel. This can even happen sometimes if you bang your leg really hard on something and injure a vessel. Factors that increase the risk: inactivity, obesity. If she has a cesarean birth, 9 times more likely to develop thrombosis. A smoker, history of previous thrombosis, varicose veins that we've talked about, diabetes mellitus. If she's been in the stirrups for a prolonged period of time during the second stage of labor, and just think about it logically, up in the stirrups for longer than an hour, what is happening to her blood flow? She has an increased chance of developing clots. No more than an hour in the stirrups at a time is the max. If she's older than 35 years old, or parity is greater than 3. She's in the stirrups, usually in not an anatomically correct position, and her blood flow is all collecting where? So just think about that. Deep vein thrombosis, signs and symptoms: swelling of the legs, usually 2 centimeters greater than the other leg. You can see erythema, feel the heat. She may complain of tenderness, and she may have pedal edema. Homan sign: we don't elicit a Homan sign anymore, because if we suspect a DVT, we do not want her dislodging a clot. So we can look for the signs and symptoms. Her extremity could also be pale or cool to touch and hurts to get up to ambulate. She may have chills or malaise. So diagnostically would be an ultrasound, an MRI, or a venography. And plus, we do not want her getting up, walking around until this gets to be definitive. Bed rest: affected leg must be elevated. We will gradually help her with ambulation when the signs and symptoms have disappeared. She will probably be on IV heparin, analgesics, antibiotics. We will put moist heat on the area, and of course lots of labs, especially with her being on IV heparin or other anticoagulant therapy. Management in postpartum: if she's breastfeeding, we will not be overlapping Coumadin with heparin. Only if she, this says Coumadin is safe with breastfeeding. Your book says, let me think on this. When she's pregnant, we can't give her Coumadin because it crosses the placenta. After breastfeeding, she can. And it'll be overlap with heparin. Initially, she's going to be given heparin, and then for maintenance, she will be given Coumadin. And she may be given Coumadin for up to 6 months. And so teaching is very important, especially what she can eat. Pregnancy, anticoagulant therapy is going to be done for 4 months, and then for 6 weeks after delivery. And during that time, and during the 6 weeks after delivery, she is not to be on Coumadin. It would be after that period of time. Sorry for that, I had to think on it for a few minutes. Protamine sulfate, what is it the antidote for? I want you to look it up so that you can put that in your mind and remember it. The antidote for Coumadin is, and I want you to look that up so you can keep it in your mind and know what it is, because those are very important, especially if some of you are going to be going to work in a med-surg area. Pulmonary embolism, this is so important because it can happen to anyone. The most common sign is dyspnea, sudden sharp chest pain, tachycardia, and tachypnea. They may feel like they're having a syncope episode, fever, but they all will have a sense of impending doom. Something is just not right. Pulmonary rales, cough, cyanosis, hemoptysis, diminished unequal breath sounds. Now this tachycardia is very tachycardic, and tachypnea, they're having a very difficult time breathing. Some of them may sit straight up in the bed. So it's important to do something quickly. You'll want to get a set of ABGs. Treatment is aimed at dissolving the clot. She may be placed on TPA or streptokinase. Oxygen is important. You need to go ahead and put them on it whenever you're suspecting this is what is happening. Analgesics, bed rest with head of bed slightly elevated. They will go to ICU. If there's no time, an embolectomy may be attempted, and of course a heparin drip. Infection during the postpartum period. This is when there is a temperature of 100.4 or higher after the first 24 hours following childbirth. This occurs on at least 2 days during the first 10 days. If she just has a low-grade fever and then it goes away, then it's okay. But if she has 100.4 for 2 days during the first 10-day period postpartum, then it probably is an infection, and it probably is bacterial. This is why it's very important that she call. It may be mastitis, but that's still a bacterial infection. Risks: normal pregnancy is an alkaline environment. A cesarean birth, a hemorrhage or an anemia, a trauma, prolonged rupture of membranes or prolonged labor, a catheterization, excessive vaginal exams, a fetal scalp electrode or IUPC, a retained placenta or retained placental fragments, poor general health, poor nutrition, poor hygiene. You know, I harp on that a lot. Diabetes or low socioeconomic status, and this is not to say that people who are of a low socioeconomic status are more prone to get infections. This is they are less able to have adequate access to care. Signs and symptoms are fever and chills, pain or redness of wounds or incisions, purulent drainage, or the wound edges are not approximated. Usually with fever, they are going to be tachycardic. There could be a uterine subinvolution, abnormal duration of lochia or a foul odor, elevated white blood cells, frequent urgent urination, painful urination, or bleeding in the urine, suprapubic pain, localized area of warmth, redness or tenderness in the breasts, and you know that could be mastitis. Body aches or generally just doesn't feel good, and this is in the table 22.3 in your book. And think of these as how they make sense. If she's having fever and chills or some purulent drainage somewhere, what is the heart rate going to do? It's going to go up. What is the white blood cell count going to do? It's going to go up. And this is just a little stupid picture. It gives you an idea of where are potential signs for an infection. Specific infections during postpartum: endometritis, usually caused from strep or E. coli, so she'd be given broad-spectrum antibiotics, usually clindamycin and gentamicin or ampicillin cephalosporins. A wound infection is usually caused from staph, so those would be broad-spectrum antibiotics and also analgesics. UTIs are usually caused from E. coli, just think about that. Broad-spectrum antibiotics again. Mastitis, staph, it lives on our skin, so antibiotic therapy and continued emptying of the breast. Physicians, some will say to pump and dump, some will say to go ahead and breastfeed. They all have differing opinions about that, but the important thing is those breasts need to be emptied so they can get well. Pumping and dumping is probably the best method of keeping them empty instead of self-expression. Mastitis can occur at any time, and I know Ms. Bradford has talked to you about this already. The correct latch is very important. Don't skip feedings or stop breastfeeding abruptly, otherwise mastitis will possibly ensue. No tight bras, a good supporting bra, because if a tight one is worn, there's poor duct emptying. Moist heat or ice can be used. Bed rest, and she must continue to pump or breastfeed, because if she doesn't, an abscess will develop, and it will depend on what the health provider says on whether to pump or breastfeed. How can we help a mom who is breastfeeding and she has engorged breasts? Not bottle feeding, not taking her bra off. Apply heat to her breast between the feedings, and cold to the breast just before the feedings will help with engorgement. Plus, changing sides. Don't feed on the same side all the time. The other side is going to be terribly engorged. Okay, Fran delivered a 9-pound, 10-ounce baby an hour ago. When you arrive to perform the 15-minute assessment, she tells you she feels all wet. You discover both pads are completely saturated, and she's lying in a 6-inch diameter puddle of blood. What is our first action? First, you're going to assess the fundus for firmness. Then you're going to take her blood pressure. Then you're going to look for lacerations, because you may not be able to see them, and then you're going to call for help. She's 40 years old. She's a G6P5. She gave birth to a 9-pound healthy boy by normal spontaneous vaginal delivery 3 hours ago. No medical problems. Pregnancy history was normal. Her labor course was normal, but her membranes were ruptured for 24 hours prior to delivery. There was no laceration. Her BMI is 36. Temperature is 99.6, pulse is 118, blood pressure is 120/70, and respirations are 20. She has an IV of lactated ringers, 1000 cc's with 20 units of oxytocin running at 125 mils per hour. What are her risk factors? Think about that. Hemorrhage risk, multiparous, obese, a large for gestational age baby, everything that we just read in the case study. A possible chorioamnionitis with slightly elevated temp, and a history of prolonged rupture of membranes. Overdistension of the uterus by an LGA makes rapid involution, which is a large for gestational age baby, makes for rapid involution necessary to prevent postpartum hemorrhage more difficult. The repeated stretching reduces the efficiency of the muscles to produce a sustained contraction and clamp down. The potential for an infection in the uterus decreases effective contraction during labor and the postpartum period, and obesity always increases our risk for hemorrhage. Based on all of that, massage the fundus. Why are we going to do that first? Because she could be hemorrhaging. But what are we going to do before we massage? Make sure she has a catheter in place or her bladder is empty. What else do we need to do? The most common reason for atony, the uterus is distended and deviated because of a full bladder. Fundus massage, emptying of the bladder, will help the uterus contract. Postpartum hemorrhage results in large blood loss over a very short period of time, so we will need to call the provider as early as we can for prompt treatment after we've done what we know we can do, or we can get her to get up, empty her bladder, and massage while we have someone else on our team to call the physician. What etiologies other than uterine atony could be contributing to this postpartum hemorrhage? Retained placental fragments, unrecognized lacerations, or a maternal clotting disorder. All of these things that we've talked about contribute to a postpartum hemorrhage. So the physician comes, evaluates Janelle, and finds there are no lacerations, and he orders Hemabate, 250 micrograms IM. And so why is this drug ordered? And now remember, I've told you to make sure you look up Hemabate. This is ordered to increase uterine contraction to decrease the bleeding. It is a prostaglandin F2 analog. It is used as an adjunct to IV Pitocin, in this case for uterine contraction. And remember, I said earlier, Hemabate, if she has asthma, is contraindicated, so it's very important to know ahead of time if she has a history of asthma. The common side effects of using carbapenem or Hemabate is nausea, vomiting, and I'm talking about a lot of diarrhea, not just a little bit. These side effects occur in more than half of patients that's given to them, so often we'll give an anti-diarrheal and anti-emetic along with it because it's like lots of diarrhea, not a little bit. What do we need to do? What do we need to assess, and how do we need to educate Janelle ongoing? We're going to for sure take vital signs every 15 minutes, abdominal palpation for the tone of the uterus, position and tenderness for bladder, vaginal bleeding. We'll assess pain. Is her voiding adequate? We're hoping that if she is developing a hemorrhage, that the physician has ordered for us to go ahead and put in a catheter. We'll assess for dizziness, any chest pain, any shortness of breath, and we will watch for what the CBC results are. We will tell her to get our assistance when she needs to get up. She needs to be voiding every 2 to 3 hours if she doesn't have a catheter. We want to increase oral fluids, high iron foods, and we want to encourage her to breastfeed, and I believe you all know the reason why. So continuing on, the client remains at a risk assessment, and this must remain ongoing. She must be monitored for increasing in temp because she is a potential for developing an infection. Tachycardia could be related to blood loss or infection. If infection develops, what is she going to need? She may need medication redosing. She is a very risky fall risk. We want to be concerned about the infant's safety when she's holding the infant. Chest pain and shortness of breath, we know what those are symptoms of. You need to remember that. We increase her fluids and high iron foods because why? She's lost a lot of blood. We want to hopefully combat potential for anemia. We're giving her oxytocin. Why? And why are we giving her hemabate? What will breastfeeding do? And how can we control her pain? Okay, this concludes our lecture on Chapter 22. I hope you were able to get a lot of application out of it on how to manage a postpartum client, complications that we may run into, how to manage those, how to recognize them. And I want you to review these things, apply what you've learned, and learn from it, because this is what the real job is going to be about. Go in and assessing what is going on with your postpartum moms, or any client for that matter. What is happening? What are they telling you? What is your assessment telling you? What are your vital signs telling you? And what are the interventions that you are going to choose? What are they going to be, and how are you going to know they're effective, or that if you need to do something else? Hope you have a good rest of the week. Thank you.